So the person who's supposed to be doing this got ill, or
No,
had a
she
conflict,
got, she is testifying in a
Oh,
case as an
okay.
expert in Texas and thought that commute might not work.
Yeah,
So they changed the trial date, unfortunately, and so she's stuck in Texas right now.
okay. So this session is supposed to be on types of dementia. Okay, and I had a few slides on my laptop that list out types of dementia. So I offered to step in and help out with this. So what I'm hoping that you will do is to ask a lot of questions, because obviously I wasn't coming in here ready to give an hour-long lecture. But I will work through the main types of dementia, but I really want to hear your stories and questions and your observations too. And I'm going to start with another quote from Richard Taylor. He's the guy I read a quote from this morning, who was the clinical psychologist who got Alzheimer's disease when he was fairly young, and wrote a wonderful book about it, and went all over the country giving lectures, etc., about what it was like to have Alzheimer's disease. And I want to start with another quote from him. He said, when you meet one person with Alzheimer's disease, you meet one person with one particular kind of Alzheimer's disease on one particular day. Okay? So we're gonna speak with some generalities here this afternoon about symptoms of different types of the dementias, but we have to understand that we are all individual persons, and that some people will have a progressive decline in mental ability, and they will remain pleasantly confused. Did you ever hear that term? We use that in long-term care up in Appleton sometimes. She's pleasantly confused. And other people will become more agitated, they will become more irritable, more angry outbursts out of frustration, sometimes because of pain that they can't describe to somebody, many different reasons. So we're all different, and even though I'm going to describe some pretty typical symptoms of all the different types of dementias, keep that in mind. We each have our own personal history. We've had our history of various kinds of mental health problems. So early in our lives, we may have struggled with a depression. And depression is a risk factor for dementia. And so depression needs to be treated for many reasons. We may have suffered from anxiety when we were younger. We may have more education or less education. We may be extroverts or introverts, right? We may have a deep religious faith, or kind of a sort of in the middle religious faith, or no religious faith. All these different things we bring to the experience of having a form of dementia. And so we need to keep that in mind as we talk in some generalities. So this is the very typical definition that's given by the Alzheimer's Association. It's very open-ended, and that's the important word. This is a progressive condition. It is a condition that sometimes people will say, okay, so what stage is it, right? We're used to talking in stages. So if you are a person who's experienced cancer, you know that there are different stages, and maybe your friends will ask you about that. Well, the same thing is true with Alzheimer's disease in particular. But once again, that too is variable in terms of the person, the environment, the history that individual has. Some days are better than other days, right? But in general, it is a progressive decline in mental ability that interferes with daily life. We all forget. And, we talk about normal age-related memory loss, right? And everybody wants to know, well, what's the dividing line between what's normal and what's not normal? Well, if it is interfering with your daily life. Some of you, did you go to, I saw somebody walking around with the 10 signs from the Alzheimer's Association. Was that the session right before this? That's really good, those 10 signs, because the way they go through and they tell you, okay, if this happens, if you make a mistake in your checkbook, fine. But if you can't ever keep it straight, if you're completely confused, if you're writing the same check multiple times, et cetera, that is really going to be interfering with your daily life. So it is severe enough to interfere. I'm going to talk to you about some newer diagnostic words in a minute, so you see that. Okay, so we've got a couple of challenges here. One of them I talked about this morning. What do we call this condition we're talking about? What do we call the people who live with this condition? Now, I talked a bit about that second one this morning, and I'll repeat myself. But I want to first talk about what do we call this condition we're talking about. So, I'm going to introduce you to some new language. Some of you may be familiar with this, may not be. First of all, a lot of people talk about Alzheimer's and dementia. You hear that all the time. I read this in the newspaper. Alzheimer's and dementia. That doesn't make any sense. It doesn't make any sense because Alzheimer's is a form of dementia. Okay? It's not Alzheimer's or dementia. I was at the session after lunch that was kind of off the lunchroom. Did any of you go to that about Down syndrome? And she used that bucket metaphor. She talked about the bucket is this general term dementia, and then there's all these specific types of dementia. So Alzheimer's disease and other forms of dementia. Now, I need to tell you about another new language change, and this one comes from the Alzheimer's Association. I'm standing in front of you here today. I could have Alzheimer's disease. I say this to my students all the time. I could have Alzheimer's disease. I don't yet have Alzheimer's dementia. So what has happened in the last year or so is that we have now got two categories. We have this one large category called Alzheimer's disease. And then we have Alzheimer's dementia. Alzheimer's disease is what is happening in the body before the symptoms emerge. It's pre-symptomatic, or another fancy term is prodromal, okay? In other words, Alzheimer's should be thought of as a disease of middle age, not a disease of old age. Because the changes that are happening in the brain start 10 to 15 years before the symptoms emerge. Okay, so I mentioned this morning I just turned 70, all right? And I could have had Alzheimer's symptoms starting 5 years ago, 10 years ago. And they might not even start to express themselves until I'm 75, right? Because my mom had Alzheimer's, so maybe I will also. Who knows if I got genes that might make me more susceptible. So does that make sense? Alzheimer's disease is, that maybe I'm starting to get those plaques and tangles. But Alzheimer's dementia would be when I start to show the progressive decline in mental abilities that interfere with daily life. Okay? So this is kind of new thinking, and it's new thinking that is promoted by the Alzheimer's Association because they are pouring tons of money into trying to figure out biomarkers. That would be, can we take some blood? Can we take some cerebral spinal fluid? Could we do some kind of MRI of your brain? Could we look at your biological situation and see whether there are changes that will then lead to Alzheimer's dementia? And if you're a person who's not yet showing symptoms, but has these changes taking place, usually in terms of different proteins that are in the brain, the amyloid and the tau proteins, maybe then there could be some kind of treatment or vaccine that would prevent the symptoms from ever occurring. In other words, so that you might have Alzheimer's disease, but we can have some intervention so that you will never get Alzheimer's dementia. Does that make sense? Now, this may not happen for 10, 15, 20 years down the road, because it's going to take a long time to figure this out, right? But that's where so much of the research is today. And that's why we're using this language a little bit differently. Does anybody have any questions about that? Does that make sense?
Are you working on something in the works right now for prevention?
Trying. It's not there yet. I mean, the prevention, in terms of a pharmaceutical intervention, you know, take a pill, get a vaccine, whatever,
Yeah.
we don't have that. Right now, the best prevention is the Mediterranean diet, exercise, social engagement. So the slogan is walk to a Greek restaurant with a friend. Okay, walk to a Greek restaurant with a friend. That's the prevention. Maybe
What if there's no Greek restaurant?
Why there's no Greek restaurant? Well, then you can cook with olive oil and eat a lot of fish and fruits and nuts and vegetables. Okay? But yeah, that's, I mean, we know that there are protective factors, right? There are protective factors like diet and exercise and social engagement, but we have no medication. Okay, so let's keep talking a bit about language. We have this word dementia, okay? This bucket term, or sometimes it's referred to as an umbrella term, okay? It's a general category to describe this progressive decline in mental function. But this has now been renamed neurocognitive disorders. So probably in about, what do you think, Kathleen, about 5 years, we're not going to really be hearing the word dementia that much, even though now we've got all these dementia-friendly initiatives going. We're not neurocognitive disorder-friendly. That's a mouthful, right? This terminology has come out, and oh, by the way, you can have either mild or major neurocognitive disorder, and this is from the DSM-5. Now, DSM stands for Diagnostic and Statistical Manual, published by the American Psychiatric Association. So the Diagnostic and Statistical Manual. It's the Bible of psychiatry. It lists every possible psychiatric diagnosis, at least as we think of them now. All right? You notice this is number 5? Right? It keeps getting changed. Huge changes. So this term neurocognitive disorder is just brand new. Okay? But in older DSMs, they used to talk about neuroses. right? Well, nobody talks about neuroses anymore, okay? We talk about anxiety disorders, or we talk about obsessive compulsive disorder, or things like that. Because that language now was abandoned about neuroses. It's an old Freudian term. We don't talk about Freud anymore, too bad. Anyway, so now we have this term neurocognitive disorder, and mild or major is just exactly what it sounds like. So if you look at the DSM, you ought to be able to go to a library and ask a librarian, just pull it off the shelf and take a look. It's quite good, quite interesting, because all the dementias or neurocognitive disorders I'm going to talk about are listed in detail, okay, in the DSM. So it's interesting to take a look at it. But they are mild or major, which means essentially that how bad have the symptoms gotten in general. Now, I am just now starting to meet people who have been handed this diagnosis. I told you a little bit about memory camp this summer. And there was a woman at memory camp who 10 months previous to coming to camp had been given, she was 68 years old, and she was given the diagnosis of major neurocognitive disorder of the Alzheimer's type. You have a major neurocognitive disorder. And that was really kind of devastating. I have another friend whose mother had been diagnosed about a year ago with mild cognitive impairment. That's actually not in the DSM-5, but it's the general term that's used by some clinicians, mild cognitive impairment. It means that, yes, you have some problems remembering things, and you can maybe get confused about days and times and, balancing your checkbook, but it's not interfering with everyday life. Mild cognitive impairment. It means that you're still driving, you're still cooking, you're still playing golf, you're still playing bridge, you're still hanging out with your friends, you're still, all those things you're still doing, but you're starting to notice some problems. There's a lot of controversy in the literature about, does that mean you are going to have Alzheimer's disease or Alzheimer's dementia, or you are going to have some other neurocognitive disorder? There's a lot of arguments. Some people say, yes, 100%. They call it conversion. You convert to dementia. But other people say, no, sometimes you get better, sometimes you get worse, sometimes you stay the same. So the research is really kind of all over the map on that one. But it was kind of devastating for these people to hear major neurocognitive disorder. But that's the language we have now, and that's the language we're going to be hearing more and more about. So, questions about that? The DSM-5? Yes?
How often do they update the DSM-5?
Good
I mean,
question.
they're on 5 now.
Right,
so-
they're on 5 now. Well, it takes a long time because they argue about it. Oh my gosh, you should have seen, getting ready for this one, back and forth and meetings, and they divide it up. So they'll have a group of people who just pay attention to the anxiety disorders and all the different types of schizophrenia and all the different types of depression and neurocognitive disorders, etc. So I wouldn't look for another one for at least 10 years.
And when did the 5 come out?
The 5 came out in, I think it was 2016, so it's pretty new. And a little earlier than that. But it's the American Psychiatric Association. So really, I do suggest if you're interested, just take a look at one at the library sometime, because it's quite detailed. So this is what you'll find in the DSM-5. You'll find a list of all of these neurocognitive disorders. And that's why I volunteered to do this, because I knew had this slide. So this is what I thought you came here to find out about, is about what are all these different types. So the reason why I've got the big fat purple arrow next to Alzheimer's disease is because right now, we think that's the most common. About 70% maybe of all dementias, maybe some form of Alzheimer's disease, but there's all different kinds of Alzheimer's disease. So, what are we talking about here? Well, there is young onset Alzheimer's disease. And that is familial. Sometimes it's called familial. That is the only one that is genetic. Okay? And it's very rare. So that what we see is in families that people start to show signs of a major neurocognitive disorder, an NCD, in their late 40s or early 50s. And then their children may start to show signs in their late 40s or early 50s. And then grandchildren. So you can see it traveling through families. There's a family down in Medellin, Colombia, or a group of families in Medellin, Colombia, where this gene has been widely distributed in Colombia. And researchers from the University of Arizona who are trying to figure out biomarkers, you know, can we look at your blood, can we look at your cerebral spinal fluid, can we look inside your heads? They're researching this group of people in Colombia because so many of them, so many families have this very rare genetic disorder. Okay? But you'll find people in the United States also who have Alzheimer's disease starting in their 40s. Again, don't encounter it very often, but it can happen. Most people will start to show symptoms somewhere in their 60s or 70s, not in their 40s. And yet, as I said, if you're in your 40s or 50s, you may start to have the changes that are taking place in your brain of Alzheimer's disease. Maybe you don't have dementia yet, but you've got the disease. So that's one of the first questions that people ask is it inherited? Okay, so that one very rare form that not very many people have, it starts very early, is definitely genetic. What about garden variety Alzheimer's disease? Is it genetic? Well, yes and no. There are certain gene alleles, certain gene forms that may put you at greater risk. And if you got one from your mother and from your father, then you may be at greater risk. Okay? If you just got one, lesser risk. Okay? And there are several of these alleles that, we don't need to get into all the genetics of it, but there are several of them that are risk factors. Okay? Now, here's a good question. Do you want to know? Do you want to go get, do you want to send your spit in to 23andMe? And I don't think they check for Alzheimer's on 23andMe, but would you want to know? Some people are paying quite a bit of money to have this genetic test. But you're shaking your head. You don't want to know.
I don't want to know.
Why not?
Because if it happens, it happens.
And right now, we don't have anything we can give you to stop it, except to tell you to go to walk to a Greek restaurant with a friend. Okay? We don't have a pill. But some people say, oh yes, they do want to know. I'm worried about this. I'll be very frank.
You know, your question about if you would want to know, I think if you polled people who are in their 20s, 30s, 40s, decades like that the answer would vary. And my guess, is that people who are, like, say, 20s and 30s, would they want to know? I would think their answers would tend to be more yes, because then you can plan.
Mm-hmm. So you can plan. And, that's why a lot of people say, yes, I do want to take the test. I want to spend all this money for a genetic test so I can plan. Other people will say, well, so what? You know, there's nothing I can do about this. One of the reasons why we encourage early diagnosis, if you are starting to have problems, is so you can plan. You can take that trip to Europe that you've been putting off. You can think about that move that you've been putting off. You can consult with a financial planner. You consult with your attorney. You can sign up for advance directive, you know, so you can plan. But I'll tell you something. I'm worried about this because there have been some very public suicides that have happened in the last couple of years by people who have started into Alzheimer's disease. One of them was by a very famous psychologist, a woman who I had, you know, just really learned so much from her, and I never met her in person, but I knew her work really well, and I was so shocked when I found out that she had committed suicide, and she had insisted that in the obituary that it be written that she had done this, and that she had determined that she would do this for the sake of her children and grandchildren. This is I tell my students this all the time, this is an issue you're going to have to wrestle with. Okay? This is an ethical issue, this is a moral issue that we are all going to have to be thinking about. Okay? Are we going to just accept this? Or are we going to try to create communities that say, we'll walk with you through this journey of Alzheimer's disease or whatever it is. We're not going to abandon you. We'll help you have the best life you possibly can. I leave that for you to wrestle with, but I urge you to take that question to, talk about it with your friends, or if you're a member of a congregation, talk about it with people in your faith community. What do you think about that? Because as we get closer to being able to identify these biomarkers, we already can identify the genes that put you at risk. What are people going to do? Okay, just a little.
So there's no
Yeah.
two Alzheimer's with people the same?
No, two.
People that have Alzheimer's, do they all have it the same, or is everybody different?
Well, what they have the same are those changes that take place in the brain. Okay, they've got plaques and tangles and other kinds of changes that take place in the brain. How it gets expressed may be very different, because we're all different from one another.
Well, that's what I'm thinking.
Yeah, we're all different. So yes, there are some symptoms that people may share in common, but we can, lots of people can have the flu, but some people will say, yeah, right, I'm gonna go to bed and not talk to anybody for a week, or I'm gonna spread it to everybody. Okay, yes.
You said there's nothing you can do if you've got Alzheimer's. Where does Aricept fit into this discussion?
Where does Aricept fit in? Aricept is one of the most commonly prescribed drugs, been around for 25 or so years. Aricept they claim, will perhaps slow the progression, okay? It is trying to target a certain kind of neurotransmitter, a chemical in the brain that is associated with memory, acetylcholine. It works for some people, doesn't work for other people. It causes some people side effects that are really unpleasant. I'm pointing to my stomach. So Aricept is often given in combination with Namenda, and Namenda addresses a different neurotransmitter. So some people do well for several years on Aricept and Namenda, but at some point then you wonder, is it really doing much anymore? You know, and that's where you really need to have your doctor be knowledgeable about this. Good question. So Alzheimer's disease, again, it typically is expressed through the memory problems that we talked about this morning, the lack of stickiness, inability to learn and retain new information, to solve problems, to make decisions, I'm talking about decisions like present somebody with a menu. What do you want? You know, they may be having trouble reading the menu, but then to make the decision, very hard. So those of you who went to the 10 signs, you saw all those 10 signs. Confusion about the day, the time, etc. So those are typical symptoms with Alzheimer's disease. Or sometimes it's mild, sometimes it's major, remember, in CDs. The vascular disease is what we often think of in terms of strokes, an accumulation of small strokes. You heard of TIAs, okay? So it's the ischemic attacks, the traumatic ischemic attacks, and so you have a small stroke, which means that a blood supply to part of the brain has been cut off, and that part of the brain now can no longer function. And you may notice something at first, but then life goes on. And then you have another small stroke. You may notice a little more. You notice maybe the face is sagging a little bit, maybe there's some focal symptoms like you're not going to be able to use your right hand anymore because something's going on in the left hemisphere. Maybe you have a major stroke, okay? So vascular dementia is associated with this accumulation of small strokes. It used to be called multi-infarct dementia. You ever heard of that? Anyway. This one is very much found in certain populations where there is a high degree of hypertension. So you need to control that blood pressure. And so walk to a Greek restaurant with a friend and remember what's good for your heart is good for your brain, right? So Mediterranean food's good for your brain and your heart, and it's good for, exercise, it's good for your heart, et cetera, et cetera. So vascular disease is perhaps the second most common type of dementia associated with stroke. Frontotemporal.
I have a
Yeah,
question
go ahead.
about the vascular.
Yeah.
My mom has been diagnosed with that.
Uh-huh.
And my sister who lives up your way asked me why people can't detect when they're having a stroke. Why they can have the succession of many strokes. I was wondering if you could shed any light on that.
Well, sometimes they do know. And sometimes people will get like a really fierce headache, associated with them having a stroke. And sometimes they'll know because they'll feel the loss of ability to have conscious control over facial expressions.
My mom's got Bell's palsy
Oh,
also.
she does
so
have
she's
the Bell's
got-
palsy, so there's that
She's
problem
got the
with that
niggling
too.
and that kind of thing.
Yeah.
But I was wondering about that kind of myself, is why you can't tell when you're having a stroke.
Well, I think sometimes people can, and it depends on what part of the brain it's taking place in, okay? I have a friend who woke up one morning and she had had a stroke in her occipital lobe, which is in the back of the head, and that's the part of the brain for vision, and she just had an enormous black hole in her vision. And it wasn't her retina, it was because she had had a stroke in her occipital lobe, so she knew, so it depends, yeah.
Okay.
Yeah, because some people will know too, and you know, they'll tell you, if you feel like, you know, particularly if you have high blood pressure. And so
Which he does.
you know, you can feel when that blood pressure is really high, because I've had that happen. And, you know, you're supposed to go in and look in the mirror, and if you see part of your face sagging, call 911. Yeah.
Now, the only thing she's ever been able to say is like once in a while, like on a Saturday morning or something, she'll call and she'll say, I just don't feel right, can I cancel my hairdresser appointment? But she can't really,
Express what doesn't feel
Yeah.
right, yeah. Just, something's off.
yeah.
Yeah. Yeah, it all depends on where it's taking place.
Okay. At least I have somebody to tell me. I can't get her to get down by you.
Oh,
She's right there, she lives in Appleton.
Oh,
She lives on College Avenue.
oh, really?
Yeah.
Okay. I want to go to the library and read the DSM-5.
I will.
There's a long description of vascular disease in there. Frontotemporal. You're hearing more about this these days, and this is one of the reasons why I'm really starting to talk about the dementias, and the person has a dementia. Because sometimes when we hear dementia, we just think Alzheimer's disease. And that's not right. First of all, it leaves a lot of people out. I once showed a slide, sort of like this, at a conference a couple years ago over in Minnesota. And so I was talking about different types of dementia. And afterwards, I was so touched by this, I'll never forget it. A couple came up to me and they said, thank you for showing us all these different types. They said, we were wondering maybe we should leave this conference. The wife had supranuclear palsy, okay? And they said, we were wondering if maybe we should leave this conference because everybody's just talking about Alzheimer's disease. And they felt like maybe they weren't in the right place, okay? So we really need to be more inclusive because there are all these different types of diagnoses of the dementias or neurocognitive disorders. And it's not just Alzheimer's disease. So frontotemporal does not start with memory problems. Everybody thinks about dementia with memory. And folks with frontotemporal could be just remembering just fine. But what's happening with them is, well, there's many different kind of subtypes of this. But, so the frontal lobes are here, temporal lobes are here. On the left side, if you're right-handed, I'm not going to talk about you lefties because you're really interesting. But anyway, if you're right-handed, your language area is in your left hemisphere, okay? Your left temporal lobe. And what happens sometimes with people with frontotemporal, if this left temporal lobe is affected, they may lose their ability to understand spoken language. So they just can't hear and make sense of words. Or they may lose their ability to speak. Okay? But their memory's okay. All right? They may have frontotemporal that is more focused on some deterioration in the frontal lobes. Now these frontal lobes are really important for the executive functions. That means our ability to make decisions, make good decisions. Our ability to plan. Okay, I want to do this, but in order to do that, I need to do this, 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 and this, okay? All of those kinds of things may be affected when the frontal lobes are affected. And the other thing that is affected is our ability to inhibit responses. The frontal lobes have the stop mechanisms in them. So this is something that my college students all understand because all I need to say is, okay, when somebody gets drunk and they do stupid things, why are they doing that? Well, they're doing stupid things because alcohol affects the frontal lobes first. And alcohol then turns off the inhibitory mechanisms, the stop functions. And so you who would never dance on the table, You're dancing on the table, right? Because the stop function got turned on. Well, that's what happens with people with frontal temporal. So that the individual who may never have shouted at other people, may never have been rude, may never have insulted, may never have hit, may never have had a temper tantrum, whatever. They may do that now because they don't have that stop function. So there's different forms and expressions of frontotemporal, but very often coming through personality. And I've seen people with frontotemporal who can go from being pleasant and happy to being, you look like you know about this, to just being overcome with anxiety, right? Or anger, right? Yeah.
I found the best thing to do is just go up, grab them, give them a hug. It helps calm them down.
Not everybody. Some people that may scare them, okay? But you know, you have to know your person. Yeah, you know your person and you know what will help. So this is really hard for families. You know, Grandma has been the sweetest, kindest Christian lady, and now she's swearing like a sailor. She may. And that's so hard. But the stop mechanisms are gone, or the kind of sexual approaches that sometimes people take, that hypersexuality. Again, okay. I see a sign back here that we need to move along. Traumatic brain injury, you've all been hearing about this because of the football players. You have heard of CTE, chronic traumatic encephalopathy, which is what they're diagnosing by looking at the brains of football players who have died, sometimes really sadly by suicide, other times, car accidents, whatever. And what they find is a buildup of that tau protein in particular in the brain. So more generally, we talk about TBI or traumatic brain injury that is associated with the dementia. Okay. So that's going to have a collection of symptoms. Some of it's going to be memory, some of it's going to be the effects on mood. So depression is a real issue for folks with TBI, and we need to pay attention and treat the depression, because depression is treatable. But this is something we're learning about more. I did a study a year or so ago in the Appleton, Oshkosh area, looking at vulnerable populations, people who lived in our 2 homeless shelters, our 2 at maybe for Harbor House for domestic violence, and Christine Ann down in Oshkosh for domestic violence, and also a shelter for people with substance abuse. And we were asking them about head injuries. Much higher percentage of individuals who had had head injuries than in the normal population. Okay, so these are individuals who are at risk of dementia because of the accumulation of head injuries that they have had. And the same thing is true for these football players who have had multiple concussions. Yeah.
Wouldn't you also see it in military veterans?
Yes, with the blast injuries, absolutely. And there's a lot of studying going on with that. Yep. We never used to think about that much, but now people are surviving those. Lewy body. Lewy body is here kind of on top of Parkinson's disease. Not everybody with Parkinson's has dementia. Some of you went to the Parkinson's presentation before, and I hope that message came through loud and clear. But sometimes Parkinson's is associated with dementia, the kind of symptoms we've been talking about. But Lewy body brings another whole problem to the fore. And that is that people who have Lewy body disease very often have vivid visual hallucinations. Now, when we hear about hallucinations, we usually think about somebody who has schizophrenia. But people who have schizophrenia, most of the time, have auditory hallucinations. So they are hearing voices. They're hearing voices sometimes that are telling them to do terrible things. Okay? But it's mostly auditory. Lewy body is visual. So a woman I knew with Lewy body one time was absolutely convinced that her brother, who had died years ago, but she saw her brother, he came in, he sat on the bed in her room. She was in a nursing home, and there were 2 beds in the room, and she had a great conversation with her brother, okay? Other people I've heard talk about, they'll look out the window and they'll see, dogs and cats running around outside the window. Most scary was the time I saw a woman in a nursing home with in a wheelchair, unfortunately, and she saw bugs crawling all over the wheelchair. Can you imagine how frightening that is? A very smart CNA just came along, took her and said, "Oh, let's put you in a different wheelchair." Okay, so you're redirected. But so Lewy body is, they're trying different drugs to control the hallucinations, to control the agitation with it, but that's a scary one.
Do they know what brings that on?
The visual
Lewy body,
hallucinations with the Lewy bodies are formations in the neurons, okay? In the occipital lobes where the visual centers are. HIV, towards the end of life, people with HIV/AIDS will sometimes develop a dementia. I need to say too much about that, but you just need to be aware of it. Substance abuse, right? Chronic alcoholism. It's associated with organic brain disease. Substance abuse, and also most of the time we talk about alcohol, but other drugs too may lead to dementia. Huntington's. Do you hear about Huntington's much in Wisconsin? You have a neighbor who died of it. I have a friend, dear friend, who adopted fraternal twin daughters when they were about 7. And at the time, they thought the mother had died of schizophrenia, and she actually had Huntington's. And now the daughter's age 46. One is in a nursing home now, and the other one is close. Huntington's is definitely genetic. So that if your parent had Huntington's, you have a 50% chance of having Huntington's. It was sometimes called Huntington's chorea, because people had a kind of jerky movement that people thought like maybe they were dancing, but it was because they were not able to, sort of like Parkinson's too, they were not able to control motor movement. Huntington's is sometimes associated with a psychotic responses, so that like with the traumatic brain injury, people will go from 0 to 100, just like that. Temporal can do that too. Okay. So they'll get very upset about things very quickly. So that's a big challenge. And you'll find that in towns there may be several cases of Huntington's because the genes have been passed around. Prion disease is the last one that is listed in the DSM-5. Prions, do you know about prions? Okay, so prions are infectious agents that are not bacteria and they're not viruses.
Mad cows.
Exactly. And the reason why, mad cow disease. And the reason why I talk about this in Wisconsin is because of CWD, chronic wasting disease, okay? Because there is some suspicion that this prion disease may get transmitted from diseased animals. Now, it's very rare, but I have met people in Wisconsin who have this. It used to be called Creutzfeldt-Jakob. Still, you hear that too?
My sister-in-law's best friend
Just died of
In the last week.
Creutzfeldt-Jakob. Oh my goodness. Yeah. And does she know how she contracted it?
30 days ago, she was fine.
Oh my word. Wow. Oh, wow. 62. So anyway, I just saw the sign from Rob that we have 5 minutes. Other questions?
Just
Yes.
with the prion disease, I lived in Europe earlier, mid-80s, and visited, spent time in England.
Oh,
when they
hoof
had
and mouth.
Right, when they have the mad cow disease and such part, so now I can't get blood.
Uh-huh.
The right thing, everything's excluded.
Let me just say one more thing. I was talking about the language. Oh, by the way, you can have more than one. Yeah. Most of the time it's Alzheimer's and vascular, but listen, folks. In 10 years, if we all got back together in this room again, we'd be probably talking about different lists. We'd be talking about certainly different types of Alzheimer's disease. We may be breaking down vascular into different subtypes. I mean, there are already many subtypes of these. So, yeah. So how do we refer to people who have dementia? Well, we don't call them dementia patients unless they're sitting in a doctor's office or they're in a hospital. We call them people who have dementia. People, persons who have dementia. Or as my very good geriatric psychiatrist friend calls them, he really does call them this, Ph.Ds.
That's great.
They're PhDs, right. Yeah. So, other questions that you have about different types of dementia? Well, thank you.
Wonderful.